Good afternoon, everyone. Today, I am going to present a journal article, Protocolized Reduction of Non-Resuscitation Fluids versus Usual Care in Septic Shock Patients, a randomized multicenter feasibility trial conducted by Lyndon et al. From Sweden, published in Critical Care on 17th May 2024. Introduction. Fluids are essential components of care of septic shock patients. There are two types of fluids. During the initial first 24 hours of ICU stay or of septic shock, resuscitation fluids will be given to the patients. These are to correct hemodynamic instability and to ensure adequate tissue perfusion. Once the patient's hemodynamics are stabilized, then the shift from resuscitation fluids to the non-resuscitation fluids occur even further after. These non-resuscitation fluids constitutes vehicle for nutrition, medication, fluids to correct electrolyte disturbances, maintain adequate hydration. Administering large volumes of fluids has shown harmful effects in previously published observational studies. From 2011 to 2018, there are nearly 3-4 observational studies was conducted where they found administration of large volumes of fluids in septic shock patients leads to harmful effects like increased incidence of acute kidney injury, digital gangrene, gangrenes, development of gangrenes, even mortality is also noted. All these trials compared protocolized reduction of resuscitation fluids with usual care, and they found no difference in the patient interested outcomes. In 2023, in Chest Journal, there was one article which was published in, it's a randomized control trial, classic trial, where they compared the usual care group with the more restricted fluid group in patients who are receiving resuscitation fluids, not the non-resuscitation fluid. Even in this trial, they could not found any significant difference in the patient important outcomes. However, as non-resuscitation fluids are the major source of fluids in the first day in ICU stay, and it stands reason for that targeting non-resuscitation fluids may be the more effective way to reduce the large administration of large volume of fluids. This trial involving reduction of non-resuscitation fluids was formulated based on the previous observational study conducted by the Lyndon et al., the author of this trial. It is a multi-center prospective observational study conducted in nearly 8 Sweden ICUs. They included nearly 200 patients in their prospective observational study, and they it's a prospective observational modeling study where they instituted a more restrictive fluid protocol versus more restrictive fluid protocol, and they've analyzed the nature and quantity of fluid given in the patients patients with the septic shock, and they found with this modeling nearly 3 liters within first 5 days can be reduced by following more restrictive protocolized restriction of the non-resuscitation fluids in the ICU septic shock patients with ICU stay up to 5 days. So this current trial hypothesis is stemmed from the previous observational studies and previous randomized control trials. So the authors planned to find out such a reduction in non-resuscitation fluids as achievable in clinical practice, as it may potentially impact the patient-centered outcomes. The aim of the trial was to investigate a reduction and impact on outcomes when they followed a protocolized reduction of non-resuscitation fluids versus usual care, and they wanted to evaluate the protocol adherence in the septic shock patients. Coming to the methods, it is a multi-center parallel group randomized control trial approved by Swedish Ethics Review Authority and registered at Clinical Trial Registry, and obtained informed consent from the patients who survived. They included patients with age more than 18 years with septic shock within 12 hours of admission to the ICU, and along with that, these patients are receiving vasopressors at the time of admission. Patients confirmed or suspected pregnancy or excluded. Coming to the randomization, patients identified by the attending clinicians are selected for the inclusion, and after that they followed centralized internet-based computer-generated allocation tools, and they have stratified by the site. This allocation followed 1:1 ratio in a permuted blocks of varying size, and patients, relatives, statisticians, and outcome assessors were blinded, even though the attending clinical team was not blinded in the study. Given the nature of the intervention that the patient that the two groups of patients received. This is the trial timeline. First, whenever the patients are admitted in the ICU, within the first 12 hours of ICU admission, these patients will be screened for eligibility criteria. After attaining the eligibility criteria, within 2 hours, these patients will be started on the either the restrictive fluid group protocol or the usual care protocol. And after 3 days, these patients will be assessed for the total fluid, and at the 5 days protocol violations, and at 90 days ICU discharge and primary feasibility outcomes, and at 6 months the secondary feasible outcomes are assessed. This is the intervention followed in the restrictive fluid groups. The maintenance fluid was discontinued once the patient achieved neutral or positive balance. The enteral nutrition at an energy density of 2 kilocalories per ml was given. If at all the patient required glucose, it will be given at a dose of 1 gram per kg per day with a concentration of more than or equal to 20%. If at all the patient did not fed enterally. Enteral water or IV fluid to correct electrolyte imbalances are followed according to the local practices. IV medications are concentrated according to the trial-specific protocol. This trial-specific protocols are predetermined with the highest concentration of the drugs before starting the trial. These parenteral nutrition and enteral nutrition are followed according to the local practices, and volume used to flush the lines are also according to the local practices. This is the maintenance fluid that the patient in the restrictive fluid group received. Once the attending clinicians will assess the cumulative fluid balance, which they haven't mentioned how frequently the clinicians assessed this cumulative fluid balance. If at all the patient achieved positive fluid balance, then they will be assessed for the hydration status, whether they have overhydrated, normohydrated, or dehydrated. If the patients are overhydrated or normohydrated, they do not receive any maintenance fluid. If the patients are dehydrated, or the patients have achieved neutral or negative fluid balance, they will given a maintenance fluid according to the local protocol. In the usual care, non-resuscitation fluids according to the local practice was given. Maintenance fluid at 1 ml per kg per hour was given. Glucose solutions were used at a maximum concentration of 10%. Medications, enteral and parenteral nutrition was administered according to local guidelines. During the resuscitation phase, in both groups, they followed during the salvage and optimization phases of the septic shock, they followed surviving sepsis campaign guidelines. During the stabilization and deresuscitation phase, they followed local protocols. And the duration of these interventions in both the groups continued for the duration of ICU stay, or up to a maximum of 90 days. Coming to the outcomes, the primary feasibility outcomes, and they divided these feasibility outcomes into primary and secondary feasibility outcomes, and total volume of fluid administered within 3 days of randomization is the primary feasibility outcome, and the secondary feasibility outcomes are proportion of participants with all-cause mortality and days alive, free of mechanical ventilation, AKA and ischemic events in the ICU within 90 days of inclusion. Proportion of surviving participants assessed for health-related quality of life. Montreal Cognitive Assessment at 6 months. Proportion of eligible patients who are randomized and consented. Proportion of participants experiencing at least one protocol deviation are the secondary feasibility outcomes. Now coming to the exploratory outcomes, primary exploratory outcomes, all cause mortality at 90 days, more than or equal to one complication in the ICU stay, and days alive, days free of mechanical ventilation within 90 days of inclusion, Montreal Cognitive Assessment, health-related quality of life at 6 months. Secondary exploratory outcomes, volume of resuscitation and non-resuscitation fluids, cumulative fluid balance at day 3 and day 5, hemodynamic stability, diuretics during the first 5 days, renal function within 90 days, Glasgow outcomes extended scale at 6 months. Sample size was calculated based on the previous observational study done by the current author. And they have, in the previous study, the standard deviation of the difference between the two difference between the two groups was 2 liters, 2.8 liters. So having a power of 90% at alpha of 0.05 to detect a difference of 2 liters between the two groups require total 42 patients in each group. And they have set thresholds for secondary feasibility outcomes. These are proportion of participants with clinical outcomes were set at 95%. Proportion participants assessed by health-related quality of life and Montreal Cognitive Assessment at 6 months was kept at 85%. And eligible patients who are randomized and consented set at 75%. And at least one protocol deviation was set at 10%. Coming to the statistical analysis, 2 statisticians performed all analysis independently, and analysis was done according to an intention to treat principle and adjusted for participating site. And the feasibility outcomes were analyzed by Von Eltern test and presented as median differences with 95% Hodge-Lehmann confidence intervals. And the secondary feasibility outcomes was analyzed by one sample proportion test and presented as percentages with confidence intervals. Exploratory outcome data, count data outcomes was analyzed by Wald-Eltern test with adjustment for site. Continuous outcomes were done by mixed effect linear regression with site as random intercept. Dichotomous outcome data are by mixed effect logistic regression with site as random intercept. Exploratory outcomes, relative risk obtained using the NALCOMS data command and RG computation in R. And the p-values are not adjusted for multiple comparisons, and the p-value of less than or equal to 0.05 is considered statistically significant. This is the CUMSAT flow diagram. A total of 145 patients were analyzed for the eligibility, and out of this 142, then nearly 44 patients are eliminated because of not achieving the eligibility criteria, and one patient did not consented. Out of this 142, 98 patients were randomized to the restrictive fluid group and usual care group equally. 49 patients in each group. After randomization, 3 patients did not fulfill criteria in the restrictive fluid group, and 2 patients has missing fluid data. So 44 patients are analyzed for the total fluid in the first 3 days analysis, that is primary feasibility outcome analysis in the restrictive fluid group. And in the usual care group, 1 patient had missing fluid data. So 48 patients are included in the analysis for primary feasibility outcome. From day 3 there are total 17 patients are deceased in the restrictive fluid group and 18 patients in the usual care group, and 2 patients who had missing fluid data but other outcomes are registered are included for the further analysis in the restrictive fluid group, and one patient having missing fluid data, but having other outcomes are registered or included in the usual care group. A total of 29 in the restrictive fluid group and 31 in the usual care group were included for the analysis of clinical outcome at 90 days. And at 6 months, total at 6 months, 2 patients was deceased in the restrictive fluid group, and 5 patients lost follow-up, and 1 patient has missing data. And in the usual care group, 6 patients are deceased, and 4 patients lost follow-up, and 1 patient has missing data. So 21 patients in the restrictive fluid group and 20 patients in the usual care group are included for the analysis of health-related quality of life, and 19 patients in the restrictive fluid group and 20 patients in the usual care group are included for the analysis of cognitive assessment at 6 months. These are the baseline characteristics of the patients in the two groups. There are more or less all the baseline characteristics are balanced between the two groups. The baseline characteristics, these are numbers and percentages are included, and confidence number and constant median and confidence intervals are included, and number and percentages are included depending upon the variable that they have used. And there is no significant, as that this study is a randomized control trial, and we could not see any significant variation between these two groups in any of the baseline characteristics. Volume of non-resuscitation fluids administered in the first 3 days. We can see that restrict in the usual care group, the glucose containing fluids are the major constituents in the of the total fluid administered in the first 3 days. But vehicle, the fluid used for the vehicle as a drug was the major constituent in the restrictive fluid group. These are the feasibility outcomes. Length of ICU stay in the usual care group is 72 hours. Median is 72 hours, and the restrictive fluid group is 67 hours. In the restrictive fluid groups, a total of 6 liters was received in the restrictive fluid group, and in the usual care group, 9.7 liters, and the difference of 3.5 liters with a significant with a p-value of 0.001. And it shows a significant difference between these two groups after 3 days. And the IV fluid received after 3 days in the restrictive fluid groups, 7.1 liter, and in the usual care group, 12 liters. Here also we can notice there is a significant difference in the fluid that the two groups have received. This is a box and whisker plot. Here we can see that the total volume of fluid administered during first 3 days was significantly higher in the usual care group than the restrictive fluid group. And these are the total daily fluid volumes in the first 5 days in the usual care, in the restrictive fluid group and in the usual care group. We can see there is a in day by day, total daily fluids are more in usual care group in comparison with restrictive fluid groups, and this difference is less appreciated after 3 days. Coming to the secondary feasibility outcomes, proportion of eligible patients who are randomized and consented are 67%. And within 90 days from the inclusion, proportion of randomized participants experiencing at least one protocol deviation was 15. Proportion of participants with clinical data on all-cause mortality, days alive and free of mechanical ventilation, acute kidney injury and ischemic events are 100, 98 and 98 respectively. At 6 months from inclusion, proportion of participants with clinical data on Montreal Cognitive Assessment and health-related quality of life are 75 and 79. And in these secondary feasibility outcomes, only the proportion of participants with clinical data on all-cause mortality, days alive free of mechanical ventilation, acute kidney injury, and ischemic events achieved the set thresholds. But the proportion of eligible patients who are randomized and consented, and proportion of randomized participants experiencing at least one protocol deviation, and the proportion of participants with clinical data on the 6 months outcome did not achieve the target thresholds. The protocol deviations, nearly 8 patients are not eligible, were included in the trial, and which constitute 15%, which is higher than the set threshold by the trial, which is 10. Coming to the exploratory clinical outcomes and harms, at 90 days from inclusion, all-cause mortality, one or more complications like AKA or ischemic events, days alive and free of mechanical ventilation, and Montreal Cognitive Assessment and health-related quality of life. There is no significant difference in these exploratory outcomes in either of these groups. Total volume of non-resuscitation fluids within 3 days, we can see there is this in restrictive fluid groups 3.6 liters and in usual care groups 7.3 liters, with a difference of 3.3 liters, which is a significant. And no suspected, unexpected, severe adverse complications occurred in either group, and no significant difference in AKI ischemic complications, vasopressors, lactate, SOFA score, diuretics, and Glasgow outcome scale extended at 6 months. Here we can see the cumulative fluid balance on day 3 from inclusion and the cumulative fluid balance on day 5 from inclusion are significantly different between these two groups. And here the total volume of non-resuscitation fluids within 5 days of inclusion is also, we can see there is a significant difference in this total volume of fluid. This is the cumulative fluid balance that as the cumulative fluid balance is also significantly higher in the usual care group than the restrictive fluid group. Coming to the discussion part, the authors primarily discussed about the interventions leading to decrease in the fluid administration in first few days of ICU stay, and the reason for not meeting the feasibility threshold in certain proportions of patients. And they discussed potential adverse effects of intervention, and they discussed about the patient-based outcomes and strengthened limitations. The intervention reduced cumulative fluid balance by 3.6 liters during the first 3 days when in comparison with usual care. The feasibility thresholds were met with participants with clinical data at 90 days. But the feasibility thresholds are not met for survivors assessed for cognitive function, health-related quality of life at 6 months, participants with the protocol deviations, and eligible patients randomized and consented. The reduction in fluid administration was twice as large as the most restrictive fluid trials. This is the restriction of intravenous fluid in ICU patients with septic shock. In this randomized control trial, patients with septic shock, where the restrictive fluid group received 1.7 liter and the usual standard fluid group received 3.8 liters. But in this trial, there is no significant difference in the patient important outcomes, even though there is a nearly 2 liters of fluid difference between these two groups.
Also, that study especially did not compare the non-resuscitation fluid. This is the resuscitation fluid which
This
has
is
been
resuscitation fluids. Yes, sir. This is not conducted, not focused on the non-resuscitation fluids. They focused on the resuscitation fluids. Yes, sir. Coming to the reduction was nearly 5 liters in participants who stayed more than 3 days, and these results supported the hypothesis of the current trial. The separation between the groups, between these groups is influenced by the fluid volumes administered in the usual care group. The fluid administration in the usual care group was similar in previous observational studies, as well as the randomized control trials like classic trial and Canadian Swedish trial and this current trial, which is nearly 10.8 liters. Feasibility thresholds did not met for protocol deviations or the proportion of eligible patients who are randomized and consented, and this may be partly explained by the long run time time of the trial. This is the inherent nature of the small trial conducted at multiple sites. The advanced training and further development of the inclusion process represents the additional opportunities for improving these inclusion rates and protocol adherence. Coming to the potential adverse effects of intervention, reduction in glucose solutions increases the risk of hypoglycemia in this trial, and the lower lower IV volume leads to increased risk of ischemic events and AKI, and concentrating the drugs will leads to the risk of drug stagnation and obstruction of central lines was emphasized in the trial, even though there is no significant difference between these two groups in these events. Maybe because of the small sample size, they could not find out any significant difference in these adverse events. The study did not affect detect any effect on patient important outcomes. The study did not detect any effect on potential adverse effects, and these results may vary from studies focusing only on restricting resuscitation fluid administration. Hence, a trial powered to detect effect on patient important outcomes and potential adverse effects is warranted. The strengths of the study are they followed a pre-specified protocol and a statistical analysis plan was robust. And a few exclusion criteria increases the generalizability of this trial results. Trial as well as a result. Study design enhanced the robustness and reliability of these findings. The limitations are the pragmatic definition of usual care may limit the external validity because there is a variability in the usual care practices between center to center. The inclusion criteria were modified slightly after the inclusion of 8 patients, which may affect the patients' uniformity of the patients in this trial. Cognitive function, health-related quality of life at baseline were absent, but it can be addressed by the randomization. Flushing volumes are not protocolized. Staffs involved in the treatment, administering treatment are not blinded, which may leads to introduce a potential bias. In patients with sepsis, protocolized reduction of non-resuscitation fluid resulted in large decrease in fluid administration compared to usual care. A trial using this design to test the hypothesis seems feasible.
Dr. Vinay?
Yes, sir.
So with this conclusion,
if you stop the share screen.
Yes, sir. So what do you think about this trial? If you want to critically appraise this trial from the beginning, what do you think about this trial?
Sir, this trial
starting from the trials, name, headings, abstract, everything.
So this trial, the heading followed the PICO format of the trial name, sir, where the protocolized reduction of non-resuscitation fluids in patients. They have included includes the patients groups and the intervention and the outcome in the trial name, sir. And in the introduction part, they emphasized the lacunae in the literature. Like initially they reviewed the literature where the reduction in resuscitation fluids did not show any meaningful effect in the outpatient outcomes, but eventually they emphasized the later observational studies where they focused on reducing
Basically, justified
fluid.
why they are doing the study.
Yes, sir. They justified the hypothesis of this trial in the
And do you
introduction.
agree with that justification? And do you think there is a fair bit of justification they have given why they conducted this study?
So the justification that they have mentioned in this in the introduction part is well appreciated, sir, because they conducted an observational study in 2018 where they found reduction in non-resuscitation fluids leads to a significant reduction in total fluid balance within 3 to 5 days, which is nearly 2 times higher than the reduction of resuscitation targeting resuscitation fluids. So they pointed the area where we need to work. So the hypothesis is appropriately formulated.
Okay, then.
Coming to the methodology part, sir, they started with this trial was in the author's mind nearly from before this trial begins. They published the protocol and they published the statistical plan for statistical analysis. Nearly this was in 2023 February and 2023 December, respectively. And then they followed the they registered for the clinical trial registry and they started the trial. So, and this indicate the robustness of the methodological part. Coming to the methodology that they have followed, sir, they clearly defined the restrictive fluid group. And even though they led the usual care group to the management of the usual care in the usual care group, led to the attending clinicians discretion in their respective centers, but the restrictive fluid group, they have a stringent protocol. This is one point that we that we can appreciate. The second one is the statistical analysis that from the beginning of the sample size calculation to the analysis, they addressed every possible events, like they addressed the non-normality of the data, and they used the appropriate statistical tests like Von Eltern test and so on.
And that is okay, but one part that you missed during the methodology is that protocol violation. So
Yes, sir.
yeah,
Yes,
so around 7 or 8% they have in the beginning are in the different, like, can you explain those part?
sir. Yes, sir. So initially, nearly 8 patients are eligible, but they haven't. Initially, they evaluated for the eligibility, but later they found these patients are not eligible. In these 8 patients, the lactate which they have assessed after inclusion was less than 2, which make them not eligible for the inclusion. So maybe inclusion of these patients into the trial may dilute the introduce the bias, because all the patients in the inclusion in the restrictive as well as in the usual care group received followed the sepsis 3 septic shock definition, which if they included all those 8 patients, maybe the external validity can't be achieved.
Anyway, external validity with this small sample set is not an issue, but definitely that dilute the issues in one aspect. So next, regarding the result, what the result, can you comment on those things?
Yes, sir. In the primary feasibility outcomes, they achieved whatever the hypothesis that they have kept, sir. They achieved nearly 3 liters difference between these two groups. 3 liters difference between the restrictive as well as usual care group by following the stringent protocols in the restrictive fluid group. But they could not achieve the secondary feasibility outcomes, like proportions of patients with protocol violations, proportion of patients eligible and randomized, and these are like this. But the patients with outcomes at 6 months are there is no significant difference in the patients' outcomes at the at 6 months. Maybe because of the long-term nature of the trial and small sample size, maybe deviations will be there. Deviation will be there. Maybe they need to focus on training the outcome assessors and setting a protocol to record the data will improve the trial precision, sir.
Okay, and regarding the conclusion, do you agree with the conclusion?
Yes, sir. They concluded with the they concluded that they following this restrictive fluid following the protocol for the restrictive fluid group, they can achieve the they can decrease the total fluid volume that administered to the patients with septic shock. But even though the patient important outcomes are not difference between these two groups, provided that the small sample size and long run of the trial, they emphasized on the larger trial, emphasize on larger trial to evaluate the patient-centered outcomes and adverse events. So they appropriately concluded the trial.
So do you think you will apply this principle in your clinical practice, or this is going to have a clinical applicability in the general practice?
Sir, the lack of in this trial is the usual care group. The usual care group is the practices in the usual care group depending upon the center. So in my center, if I follow the protocols in my if I see the protocols in my center in the usual care groups, maybe the fluid that in our center, in my center, is receiving lesser fluid than the usual care group in the other center. So in order to replicate this, or follow these study findings, I need to conduct a similar trial in my study population, and if that trial is also showing the similar results, maybe I may.
So you are totally not convinced of the restrictive group protocol that they have used. Is that correct way?
Yes, sir.
So Dr. Jeetendra, sir, if you can ask anything.
Dr. Jeetendra,
Yeah. Yeah, sure. So just I summarize the things and little bit is
Yes, sir.
there are certain basic principles when we go through the trial. So first principle is the trial. It's not trial actually. We are not actually evaluating the trial. We are evaluating the paper. So we read the paper. Okay, that is our first step. And then we assimilate all the information which is published in the paper, and later on we evaluate. So one thing is we see all the scientific way for which it is designed, and the way the things has been actually taken care in terms of the protocol was maintained, no loss of data, no change in the protocols. I'm just giving a very, very briefly generalized view. And then we go, once we collected the data, what we do with the data, do we apply the appropriate test so that once the results comes and we try to see the what is the validity of that results, which we are really thinking and then finally conclude Sometimes the message is there, and then how we conclude. That is the one aspect. The second is now we appraise that paper. So usually we take the both things very hand in hand, appraisal of the paper and appraisal of the trial. But sometimes it is little bit a disparity over there. Like this is the example of this trial. I'll come back to again. But first and foremost, we must not miss it is the feasibility
Yes.
trial. It
Yes.
is not the clinical trial.
Yes.
So background of this trial is the author first they surveyed something. There they observed there is some signals. So there is a different way of managing the fluid in the sepsis. That was our first trigger of the scientific mind. There is something here so that we can investigate further. So that was the survey of that. Now they came to this trial. So just let me clear very thing. Once they conclude, try to understand this conclusion is not at all for your clinical practice. This conclusion is whether now you can conduct a primary endpoint directed your clinical outcome with the randomized control trial, because their primary outcome here was not at all the clinical parameter. There was mainly concern is the heart of this trial is whether we can conduct the trial this kind of or not, whether we achieve to that. And second, during that, first is the feasibility outcome. That's why the author mentioned over there. And second is the exploratory clinical. That means you are not testing any clinical. The way you are going for some project and you are able to achieve, but simultaneously, have you made some collateral damages over there or not? Just to see that. You cannot conclude with that this would be a clinical outcome, but just to check. That's why it is almost equivalent to the pilot and kind of initials. Just here, if we believe in the conclusion, that means we are agreeing now we can conduct a more trial for that. That is the main heart of this thing is it is not giving you any clue about whether you change your clinical practice as if now or not. This is mainly based on the whether the trial can be possible or not. So you say that given is the fluid restriction was there, so it is there. We reach to the population which is required for the primary outcome, which we already calculated. So that was a basic heart of this thing is. Now come to a little bit. So I pointed out the difference between critical appraisal of the paper and critical appraisal of the trial. So how beautifully that here you can make the difference over there is when we appraise the paper. So right from start, who has written, what the introduction is adequate or not, what all the parameters are there or not, because we don't know what exactly the researcher did, but they really included or not. So we categorize, yes, it is okay, the checklist is okay. And when we see the discussion, whether they made their limitation or not, all the limitation possible, and they hear it. So it makes a very good paper, but something is missing and you are admitting I am missing that thing. That means suppose just analogy over there, if somebody accept the crime I did this, that doesn't mean he is free from the crime. So whatever indigenous problems were there in the trial, though you have discussed in your discussion segment, that makes you a paper robust, but makes still a little bit whatever the problems and controversies or unanswered things related to the trial would be there. So whenever we appraise the trial, doesn't mean we just categorize yes or no, bad or no. No, we are just seeing what is there or not, which is the actually we will believe on that results or not. So that one thing must be kept in mind. This is a feasibility trial over there, and the primary calculation they did is the just for the whether the 90 days you are able to complete or not. The rest of the data which you see just there is. So initially they recruited 49, if I'm
Yes, sir,
correct.
49.
Yes.
Yes.
So even 3 days. So few people actually dropped 49 to 44.
Yes, sir.
And then further 17 patients
Sure.
in the intervention group or restricted group, and the 18 is the disease. So that is a really problematic thing. because you really don't know if they would have been alive, whether they received or what are the negative outcome, then you capture it. Once the death is there, then obviously it makes you a little bit. So going forward, whenever the study goes down and down, the power related outcome becomes automatically reduced over there, because initially the power was on higher, the overall the outcome gradually your study population shrunken, your outcome, and then when you reach up to the 6 month, then you believe that they remain with the 19 patient in the intervention 20, less than half of the patient of that. So even you, whatever you make even though at the secondary endpoint also we didn't calculate the power for that quality health related quality of life and cognitive assessment. So it becomes a technically, to be very honest, these are the purely unnecessarily added outcome. This study is neither meant or nor give any answer for that, because that was not the primary aim and over there. Now the one thing is again important in this thing. They divide into two parts: usual care and the restricted care. That was a protocol of study. But the maintenance fluid restriction itself was not protocolized. That was left to the individual kind of this thing is. So again, don't get any question like whether it makes a study bad or good. Don't try to dichotomy bad or good, but just really need to really see that these are the intricacy over there. The protocol was there. Protocol for the keeping the patient in the restrictive and the usual care, but the restriction itself was not protocolized, so it makes a little bit, and the usual care is so much diversity over there, so that in. And one point is again important. Sometime we are having some limitation, and we glorify that limitation into the advantage, keeping the exclusion criteria one only. That gives you very good for the generalizability, but technically makes you a little bit, because heterogeneity would be over there. So basic aim of research is try to give the one answer for the one problem. That is the main issue for the modern research. Either you get a precise answer or get the generalizability. If you become so much precise, then your generalizability will be lost. And if you become so much generalized, then your precision would be lost. That is a kind of this here is, because the septic patients mainly divide into the two part is like LV dysfunction or without LV dysfunction, and that makes you a little bit. And here that wasn't a provision word. Though again, we should not keep this thing in mind. It will not make you good or bad, because the primary the study design was the feasibility study design. We just need to see whether this research is possible or not. So to that, this study very well achieved their hypothesis and targets. Yes, it is achievable, and immediately they don't foresee a major drastic alarming sign, so that you cannot conduct a further well constructed focused randomized control trial based upon that, because they didn't see unusual kind of ischemic events and all these things. So that's all from my side to really, but rest of the thing Dr. Ray is excellently.
Excellent. No, sir. Excellently put everything forward. Everything is okay. The first thing that I want to emphasize also, it's a feasibility trial. So definitely clinical practice will be the secondary aim. One thing I 100% agree is that why they go into those quality of life markers, that does not make sense. And they have not discussed much about in the discussion also there. So they have calculated that, and that is nothing. Another thing is that the dropout is very high, and with that dropout, they have not, it's a multi-centric trial. So, and they have not compared between the centers how robustly they have practiced the strict restriction and the usual care in those places. Although the protocol for the restriction is there, it is not robust. If many things are on the discretion of the physician who is treating them. In a post-op case, it's different. In a normal ICU care, it's with the physician who decides. In a perioperative case, it's the anesthetist who is deciding. So those are the limitation of this. Logically, it definitely makes sense to restrict the fluid. Further, and what they conclude that it is feasible to achieve those protocols, but to what extent those protocols should be limited, we don't have an answer, because the sample size is less. The concern raised by the authors regarding the potential complications are valid, But those, if you are concentrating so much the fluid, is it going to affect really or not? If you are decreasing the fluid, is it going to increase the incidence of AKI or not? Or how much restrictions would be there? Those questions need to be answered definitely. Anything else?
One more small
yeah.
point. First of all, thanks to Dr. Vinay, which is very in flow and collected a very important information in the slides. Usually, general class becomes so much boring, and the people actually don't see the slide. The best thing in his slide is whatever. If somebody is a little bit taking the interest, whatever comes in their mind, the next slide will give that information. That is very important for the well constructed presentation. One thing I just say, Vinay, there was a little bit of course, again, it may not be primarily our aim out there in this study. They sort of concentrated drug, the possibility of stagnation or there or not.
Yes,
And of course, you made a statement like we can't say because of the small size. But let me be very clear, small size is not a limitation. Here is we don't have any tool for that.
yes.
Suppose our size would have been thousands of the patient, but we don't develop, we are not having a tool to really see the drug stagnation happening or not. The final clinical outcome depends upon the so many variables, you can't really know about that. So these are the few things you really go into the deep into the study and you find, yes, in the paper writing, certain maybe over enthusiastic young writer was there, so they just make a kind of this thing is because of course he raised the point of there is a possibility of drug stagnation because so much concentration was there. Whether we are not able to make it out whether it happened or not. That is right. But can we make out with a large sample? No. Until unless we don't have a tool for that. If we are having a tool, then all. Just a small thing, nothing.
Yes.
Dr. Bansal, any final remarks?
Then you anybody from the
Audience.
audience?
Any questions from the audience? And Dr. Vinay, would you like to ask anything or comment anything apart from the presentation?
Sir, can we replicate this same trial in our setting and the findings can be
in fact, that is the ground for not only the your setting, is still no randomized control advance. So even just for the saying, even you don't use the this thing is can I replicate in my center? The stage is open for the you can replicate for the whole world because that gave the you can say platform for the next trial. So there would not be now ethical issue and kind of this thing is probably if you design the randomized control before this trial, probably some ethical maybe possibility over there because they don't know any answer and there is a little bit seems to be a provocative test which may somebody lose over there. So there could be a ethical issue. But based upon this trial, now you can construct the randomized control trial with your primary endpoints because this is not primary endpoints was
Clinical outcomes.
not the clinical. You're definitely, and of course on your center, definitely.
So anything else?
In fact, in this trial, the clinical benefit is there because so much our practitioner, young and even the older one, more than the older one, even they don't know the importance of the non-resuscitation fluid is going on. Well, on the background, the fluid is going on. There are a lot of antibiotic which we give a 4 hourly, 6 hourly, and all these things, and let's keep on dissolving whatever 4 antibiotic with the every time 100 ml, and the some are 3 hourly, 3 times a day, 4 times in a day, potassium supplement, this and that. That carries so much fluid and people forget about that. That makes a little bit sense for hearing somebody read this paper that gives that is the clinical help which we can get.
Thank you, sir. Thank you for your appraisal and valuable comments. Dr. Ray, sir, any final comments?
No, as Dr. Jeetendra summarized this very well. So the intention of the authors are very clear and they are able to achieve that intention that at least these restrictive protocols are feasible in a setup. Otherwise, whether the clinical outcomes, variable outcomes, clinical outcomes are going to help or not, that require a larger study with a larger sample size. That is the need of the hour. at least what I get is that if, like Dr. Jeetendra say, if somebody read this paper, many times these non-restricted fluids are ignored. You next day you check you restrict the fluid, then also find out that there is whatever you target to achieve is not there. So these things, at least people will be much more cautious about decreasing these non-restricted fluids, which has a potential for a better outcome in the septic group patients. Otherwise, a further trial is really warranted.
So I think that was very nicely presented by Dr. Vinay Gandhi. Thank you, Dr. Gandhi. And thank Dr. Bikash sir for making it possible for his appraisal. And I thank Dr. Jinna Sharma sir for his valuable comments and appraisal. So I thank the audience, and I think we shall repeat it again after a few weeks. So intermittently, we'll have the general clubs as per your request. And I think you will find it useful. Please give your comments in the chat box when the video is uploaded on the YouTube channel. So thank you, everybody. Thanks, sir. Thanks, Dr. Vinay.
Thank you.
Thank you, sir.